Welcome, everybody. This is a very special occasion today for us to review and reflect on the first 2 years of the International Institute for Primary Healthcare in Ethiopia. My name is Henry Perry. I've been the coordinator for the Johns Hopkins collaboration with the Institute, and I want to welcome you, those of you who are in the audience, as well as those who are joining us by internet. So welcome to all of you. I know some of you are in Ethiopia, and we hope other countries as well. What we're going to do today is hear from some very distinguished people, talk about their reflections on the Institute, and then we're going to have a moderated panel discussion. Leading off, I'll say a few words about the origins of the Institute and what it's doing at the moment, and then we're going to hear from Dr. Kesete Birhan Admasu, who is the chair of the advisory board for the Institute, was the Minister of Health at the time this started in Ethiopia, and is currently the CEO of the Rollback Malaria Program. And following his presentation, we'll hear from Professor Mengesha Admassu, who is the executive director of the Institute. Both of them are not here physically, but they have prepared a video to share with us today, so we'll hear from them. And then after that, we're going to have a discussion that's going to involve some very interesting people. And Margaret Cornelius has just arrived, so please come up and sit here. We have a seat for you. Margaret is the program officer from the Gates Foundation, who's been responsible for overseeing the grant that we have from Gates to support this work. In addition, we have Mr. Oying Rimon, who is the director of the Bill and Melinda Gates Institute for Population and Reproductive Health. And then next to him is a person of great renown that many of you may not know about, but he was one of the faculty members newly arrived at this school when I came here as an MPH student only 48 years ago in 1970, who started his career in 1957 as a medical missionary with the Swedish Baptist Church in Ethiopia, and has continued to be involved for many, many years now in the primary health care and community health work in Ethiopia. And he lives in Seattle, but just happened to be here today. So it's great to have you, Dennis. So let me start out with sharing with you just a few words about the Institute. This Institute exists because of the success of the transformed primary health care system that Ethiopia developed under the leadership of the man who is now the Director General of the World Health Organization, Dr. Tedros, and his protege, mentee, Dr. Kesete Birhan, who was the Minister of Health after Dr. Tedros. And that transformational primary health care system that was developed was based primarily on the Health Extension Worker Program, which involves now some 40,000 women, all women who have 1 year of training and who are based at a health post that serves 5,000 people. So each health extension worker serves 2,500 people, and they spend part of their time in the health post and then a major part of their time working in the community. And also working at the community level is the Health Development Army, of which there are some 3 million women volunteers. And you see here the health post and 2 health extension workers on the left, and on the right you see a Health Development Army volunteer who is bringing a woman and her children for immunization that came when I was visiting this particular health post. Here is the physical location of the Institute on the right, a wonderful building constructed with money from the Centers for Disease Control in the United States, and the staff that we have now of the Institute that are based at this building in Addis Ababa. And we have a very outstanding advisory board that's met 3 times now. Oying Rimon and I are on the advisory board, and as I mentioned, is chaired by Dr. Kesete, and has some distinguished leaders in primary health care from around the world. Included among them are Dr. David Sanders, who many of you I'm sure know, who is the founding dean of the School of Public Health at the University of Western Cape, and also Professor Peter Hill from the University of Queensland in Brisbane, Australia, Professor Wim van Dam, who is professor at the Institute of Tropical Medicine in Antwerp, Belgium, and other people who weren't in attendance that day or in either one of these, but we have virtual meetings, and it's hard for the staff to get to all of these meetings, of course. And this is just one example of a group of trainees that just completed their training that I happened to be at and was privileged to be a part of. Just a few words about what the Institute has achieved in the first 2 years. There have been 568 trainees that have attended courses provided by the Institute now in the last 2 years, 7 international delegations from across Africa and Bangladesh and Haiti, quite a few national trainees, including all the district directors for the country. The Institute has made a lot of progress in establishing a world-class resource, a hub for information on primary health care, still in process, and has taken the beginning steps in establishing a research agenda and has given now 5 small grants for primary health care research. Our institution at Johns Hopkins has provided faculty support with the development of training materials and the curriculum development. Our Welch Library staff has been involved in helping to set up the Resource Center for Primary Health Care. Our Center for Teaching and Learning has been involved in helping us develop the training materials that we need. The Center for Communication Programs has been involved in a number of different ways in providing support. And we've also provided the leadership for establishing committees for each of the 3 main functions of the Institute: the training function, the setting up of the resource committee, and the resource center, and also the establishment of research committee that's been meeting every 3 months or so. So with that background, I'd like to let you hear a video that Dean Clegg made in 2016 at the time that the Institute was formally announced, and then we'll move on to Dr. Kesete. Reality. Today, you are a part of this reality. We are grateful to the Bill and Melinda Gates Foundation for the initial startup funding for the Institute. And now let me share with you this special message from Dean Clegg.
Congratulations on the establishment of the International Institute for Primary Health Care in Ethiopia. The world has watched with admiration as Ethiopia has made great strides in improving the health of its population. And as you know, it's done so by using health extension workers who have become an army to improve health throughout the country. We applaud the establishment of the Institute and agree that now is the time to disseminate this model to other low and middle income countries who can benefit greatly from the advances made in Ethiopia. It is part of the mission of my school, the Johns Hopkins Bloomberg School of Public Health, to improve the capacity of institutions around the world to attack the problems that face their populations, the health problems, and to improve their health. We look forward to partnering with you in the establishment of this center to quantitate the impact of this great innovation, and also to continue to generate evidence so we can improve the quality, and then lastly, to help disseminate it to low and middle income countries through training. Ethiopia is a great country, and we know it has an even brighter future ahead. We're happy to be a small part of that future.
The Johns Hopkins University is one of the world's preeminent universities. Its global reach in terms of research, teaching, and service is unmatched by any other university in the world. Sorry about that. The Johns Hopkins... So now, sorry about that little glitch, but we want to move ahead now to the video from Dr. Kesete from Geneva.
Greetings from Geneva. Henry Perry asked me to share with you a short video explaining about the original vision I had for the International Institute for Primary Health Care in Ethiopia, and its performance over the last 2 years since it has become operational. As most of you know, the health sector in Ethiopia has gone through a massive transformation and registered unprecedented progress over the last 2 decades. And much of this progress is credited to the massive investment the government, people, and the development partners has made in expanding access to primary health care. Expansion of access to primary health care has started with the training and deployment of new cadres of health workers, which we call the community health extension workers. The country has trained and deployed nearly 40,000 community health extension workers, 2 in every village, and deployed throughout the country. So as progress Ethiopia has made become known to many countries in Africa, outside of Africa, there has been a growing interest to learn more about the Ethiopian health extension program. In fact, we used to host frequently country visit delegations whenever they come to Addis for African Union meetings, or they also specifically request the Ministry of Health to organize a site visit so that they learn the program. In 2013, when we had the International Conference on Family Planning in Addis Ababa, I was having a conversation with my good friend Oing, and I shared with him the vision I have, which is to build a primary health care institute that would take the lesson that Ethiopia has learned in expanding the community health extension programs, because as we rolled out the program, we have made some mistakes. We have learned from those mistakes. So as countries continue to show interest, it would really be important to create a platform that would effectively share the Ethiopia's experience and encourage countries not to make the same pitfalls we had as we expanded this primary health care program. But secondly, as the country's economy grows, as urban centers expand, and as a middle class grows, there will definitely be a political pressure, a public pressure to shift the focus even within Ethiopia from primary health care to secondary and tertiary care. So for a low-income country aspiring to be a middle-income country by 2025, going through the route of expensive tertiary or hospital-based service delivery model is not the cost-effective policy pathway that the country needs to take. So having an international institute for primary health care will also help Ethiopian program managers, policy makers, parliamentarians, and Ministry of Health officials to see the benefit of primary health care, not only confined to the experiences of Ethiopia, but taking stock of the experience of primary health care throughout the world. So in short, the vision is to build an institution that would share experience, Ethiopia's experience, to the rest of the world, be a catalytic player in creating this big global community that is focused on expansion of the community health workforce throughout the world, but at the same time continuously refreshing and repositioning the role of primary health care within Ethiopia as well. So these are the two pronged objectives of the international primary health care: to share Ethiopia's experience to the rest of the world, and to ensure that there is continued capacity building, repositioning, and refreshment of the primary health care approach in Ethiopia. So as we started to formulate the concept into concrete deliverables, I reached out to Johns Hopkins University through OING and requested a partnership with Johns Hopkins University in realizing this vision I had, which is the establishment of the International Institute for Primary Health Care. You may or may not ask why Johns Hopkins. We have had, good working relationship with Hopkins University, and JHU through various departments had been actively engaged in the Ethiopian health sector through various programs. And, the strong partnership the School of Public Health had with Addis Ababa University and with the Ministry of Health was one of the reasons why I requested Johns Hopkins University to partner with us. Secondly, we wanted also to build on the international recognition that Johns Hopkins has in terms of expansion of primary health care, as well as the high quality training that the university provides to public health practitioners throughout the world. So as we have this ambition of making this a truly world-class international institute, which is anchored in a strong and successful national primary health care program, it gives the institute a unique advantage. So partnering with a world-class institution like Hopkins and anchoring the training institution within a nationally led and successful primary health extension program, I believe will give this new institute an edge on becoming a world-class institution, a go-to institution that catalyzes the primary health care movement throughout the world. So unfortunately, the whole process of setting up the institute took a bit of time, and after the institute was set up, there was also obviously political change. I left the Ministry of Health right after the institute became operational, which had probably caused a loss in momentum, but we were able to set up the board, a very good and effective advisory board that is comprised of eminent global public health leaders as well as national leaders, and the co-chair of the institute has recently been appointed as the Minister of Health of Ethiopia, which is a very good news for the International Institute, and I believe the momentum will be stronger going forward. But having said that, I think over the last 2 years, the Institute has also done a very good job. It has trained many Warada health leaders, district health leaders on primary health care, on the philosophies of the health extension program, on transformational leadership. This is really important because there is an attrition of primary health care managers, health extension program leaders at district level. So continuously providing this training is important, and it's an important aspect of the mission. And at the same time, the Institute has also provided international training and support to many countries in Africa. Professor Mengesha will be able to share the details of the various trainings they have conducted. So overall, I still believe that this institute will be a very good platform for expanding access to community-based health service delivery, and primarily, a community health workers program, which is gaining momentum throughout Africa. Even in my role at RBM Partnership to End Malaria, I work with many ministries of health in Africa and outside of Africa, and in most places where we see a huge burden of malaria, one of the underlying factors is lack of access to basic health services. So, for instance, Mozambique and Zambia recently has passed a policy to deploy, community-based health extension workers that are tasked with providing a range of services, including malaria. And basically they are modeling their programs after the Ethiopian model. Obviously, they adapt it, contextualize it to fit their own context, and we don't foresee that an exact replica of the Ethiopian program will be the solution everywhere. But the basic philosophies of the program, which is about engaging communities, fostering community ownership, empowering individuals with the right information, skills, knowledge, bringing behavioral change, and bringing critical services, core services to the doorsteps of rural, marginalized communities is the same everywhere. The content, the way the program is managed and shaped could differ from country to country depending on the political context and the political economy of each country. But the basic principles of the program, I believe, would hold true. And this growing number of nationally led, owned, community-based health service models would eventually be useful in terms of improving the Ethiopian Health Extension Program as well. There are a lot of innovations that will be going into these various programs, and these innovations and new approach and techniques could be shared as best practices, and the International Institute could play that role of documenting best practices, not only in Ethiopia, but from the programs that it has supported, and create that community of knowledge and best practices as well. So I would say that I am optimistic about the future of this institute, because we will continue to see a strong leadership from the Ministry of Health, and the institute, I'm sure, will get a lot of support from the new leadership and from the development partners. And this global movement towards universal health coverage and celebration of the Alma-Ata will bring more impetus into the work of this institute. With that, I would conclude, and I'm sure Henry Perry, Owing, and Professor Mengesha will be there to answer any questions you may have. Thank you very much for giving me this opportunity. Good day.
Okay, great. So let me now switch, and we'll have a message from Professor Mengesha Admassu, who is the executive director of the Institute. He is the founding executive director, had a very distinguished career at the Gondar University, where he served as president for
Good morning, everyone.
10 years or so before assuming this position. Go ahead, Winnie.
Good morning, everyone. I'm Mengesha, Executive Director of the International Institute for Primary Health Care in Ethiopia. I thank you very much for the opportunity to share our institute's experience so far for the last 2.5 years. Some of the greatest achievements of our institutes for the last 2.5 years were as followed. We think the achievement since its establishment in 2016, the Institute has made great achievement in 3 areas, especially in training, research, and also resource center establishments. One of our area training, the Institute has been able to provide both national and international trainees. When we take the international trainees, we provide training for delegates from Zambia, Nigeria, Tanzania, Lesotho, Zimbabwe, Haiti, and Bangladesh. The duration of the training ranges from 5 days to 8 days. And each country of delegates ranges from 10 to 15 delegates from the respective countries. We also provided training for local trainees who are Woreda health managers, zonal health administrators, and members of the parliament. It's just to keep on the right track that their successful achievements and best experience that Ethiopia has. Regarding the research, priority areas for PhD research were identified with key partners. Then a small research grant for 5 postgraduate students for 5 universities in 5 universities have been provided. Systematic review on utilization of service at PHC was conducted, and also conducted workshop on evidence to policy translation and facilitation from Future Health System and Johns Hopkins in South Africa. The Resource Center, an implementation plan has been designed by an international consultant based in the UK. At Sawa University has been involved as a local consultant to set up the electronic library system. Resources have been collected from Federal Ministry of Health, Health Bureau, NGOs, and on the internet locally, and from JHU internationally. In addition, open access journals and database have been created for users. A directory of organizations working on health was also established. Uploading of the Resource Center webpage has just started. Regarding governance and management, there is a strong advisory board which has been established, and so far 3 meetings were conducted, 2 face-to-face and 1 virtual. Valuable comments and suggestions were made by board members on the Institute's work. The Institute is housed in the National Training Center, which has excellent facilities to conduct trainings. Strategy plan, duration of 2018-2022, was developed, and the future direction of the Institute was set. Partnership with key stakeholders has been established with Regional Health Bureau, Yale Global Leadership, UN agencies, and local and international NGOs. However, we also faced some challenges. The one-year GATES project 2016-2017 could not be implemented as planned due to various reasons. From the very start, probably this fund was released from Bill and Melinda Gates Foundation a little bit late, and again from JHU to our institute was also late, transferred. But one of the very important major challenges that we faced, we think, is the management of finance and the purchase through EPHI. For instance, trainer could not be paid service fee. Purchase of ICT equipment for resource was almost impossible. Development and the revision of training curriculum could be finalized. Securing funds for a short and longer term has also been a challenge. Although the strategy plan was developed, the first year of operation has not yet started. There was no fund to implement the 2018 plan. The second point, so far, what lessons that we have learned in collaboration with Johns Hopkins University. The partnership with JHU has made significant contribution for the Institute to have aspired international image. JHU, through the leadership of Dr. Henry Perry, has been supportive from setting the strategic direction of the Institute to assisting in the day-to-day activities. Dr. Perry assigned colleagues, Dr. Mike, Dr. Ida, Dr. Terla, and Wintana, to work for the Institute on a part-time basis. All contributed to the success of our institute. For instance, the program support on the training, a training committee has been set up at JHU to support the Institute's training activities. Dr. Perry has given a training to the Lesotho and Tanzania delegates. He has been arrived in Ethiopia while the training was in progress. And there was a good interaction, and the question has been discussed, and thorough discussion on the nature of the training and what the training aspires has been discussed very well. Dr. Perry has also prepared a video to be run in his absence. In the research area, Dr. Perry and Dr. Mike, Dr. Ida has helped the research unit very well, and the research committee has been set up at JHU. When we see the resource center, Dr. Perry has donated his private collection for the resource center. He has linked the Welch Medical Library staff with the resource center, and also he set up a resource center committee, and the committee held 2 meetings so far, and the third one scheduled for the coming May 9. Members were making comments on how to establish the resource centers. Regarding the management and the admin work with JHU, JHU has supported the Institute in various management and day-to-day tasks. For instance, making visits to monitor progress of the GATES project and providing useful feedback, development of the strategy plan, and handling finance and purchase, Here, signing of contract with IT consultant at Addis Ababa University and Nansen on behalf of the institute, purchasing various equipments and public materials, covering expenses made in hard currency, for instance, for board member travels, helping edit various documents produced by the institutes. What do we look in the near future? I think the institute could do more in the future in the area of training, research, and resource center to help achieve health for all through primary health care. IPHC can continue to share Ethiopian best experience to African countries. More training programs are on the pipeline for regional health implementers. The research unit could contribute to the improvement of PHC in Ethiopia through evidence-based research and policy dialogue. More research is planned through small grants to university students. The resource center should be further developed to incorporate more resources that could be helpful to Ethiopia, Africa, and beyond. Regarding its governance and management, if the institute secures its autonomous status in the near future, the challenge faced in the previous year could be eliminated. The institute could take advantage of the interest shown by international donors in the area of PHC and could raise more funds. By partnering with JHU that have rich experience around PHC training and research, more could be achieved. Having said this, it's a great opportunity for us having this chance and privilege that on behalf of the International Institute for Primary Health Care, I want to thank Bill and Melinda Gates Foundation for sponsoring this operational plan duration, and also for successful technical advisory of GHU to strengthen the capacity of our institute. I hope, with the great interest of Bill and Melinda Gates Foundation supporting primary health care all over the world, we're also very glad to have this chance again, and also very glad to work with Johns Hopkins with their technical support as well. Thank you very much for the opportunity again. I thank you.
We'd like to move now to a moderated discussion. I'd like to invite Margaret Cornelius from the Gates Foundation, who I'm sure was stuck in traffic and was a little late getting here. But we want to welcome you, Margaret. And so I'd like to start out with a question to Dr. Dennis Carlson. I mentioned his early work as a medical missionary beginning in 1957. After 4 years of doing that, he became the dean and director of the Gondar Health College in Ethiopia, which has a very distinguished history in primary health care in Ethiopia, and later joined the faculty here back in the 70s, as I mentioned, but has continued to work off and on with many different organizations, Save the Children, the Carter Center, currently has an NGO that he's actively involved in nutrition work, and has watched this transformation of Ethiopia and its primary healthcare system. So, Dennis, you have the big view of this, and I know you have an understanding of the need to be patient as these kinds of changes continue forth, which we hope the Institute will provide.
Thank you, Henry. It's a great privilege to be here. I love Hopkins, but I love Ethiopia more. And so anytime I have a chance to be involved, I'm very happy. It wasn't until after the Ethiopian government was able to drive out the Italians in 1941 and then to move the British out also, who wanted to control the country as a protectorate. It wasn't until 1948 that the government really began its own modern health services. It called upon WHO, UNICEF, and the U.S. State Department to assist in this process. And at that time, there was practically no physicians, perhaps one or two in the country. There was no medical society, there was no nursing society, and these were all very big advantages. Because the Ethiopian representatives working with the World Health Organization in particular posed a radically different kind of health system, not clinics and hospitals, but primarily health centers, which combine and integrate for populations of 50,000 people approximately, the work of clinical, preventive, promotional health services with a team. A health officer, a community nurse, and a sanitarian, and added some other kinds of workers later. And this began as a college in an area of northern Ethiopia called Amhara now, and it was to be a demonstration for the country as a whole of how modern health services could be delivered. All of these things took time. When I came as dean in 1963, there had only been 11 graduate health officers the year before. And we said we have to build our teaching staff and the volume and the numbers of students that we trained, and so we worked really hard on that. But the graduates of the college became the managers of district health departments, regional health departments. One became vice minister of health, another one became minister of health, who happened to be a community nurse who had graduated from the public health college. Also, two university presidents came from the graduates of the public health college. During the next regime of the Derg Mengistu government, a very large and optimistic, hopeful kind of program based on 3,000 community health agents was launched, but they provided practically no supervision, practically no supplies, and no compensation for the community health agents. They were supposed to get it from the farms that they were working on. The next regime, the EPRDF, the TPLF, again said we lost something very important when we lost the health center team, and reestablished an emphasis on health centers and said that we're going to build 3,000 health centers and we're going to train 5,000 health officers. They had lost the community nurses and the sanitarians in the process through the decades. They moved into 7 new universities with health science programs and health officer training, and they moved very rapidly. Today, there are 3,740 health centers in Ethiopia. There are 10,000 health officers working in Ethiopia. Most of the new universities, and there are now over 30 universities in Ethiopia, have a health officer program. And today it has moved from 11 graduates the first year that I was there to a cadre of 10,000. I would urge everybody involved to be patient. Many, many things take years, decades. Public health effects really aren't seen before 20 years, as we are taught many, many times here in this very auditorium. So So what is being done is really valuable. It should continue. It should grow deep roots. Thank you very much.
Thank you very much, Dennis. Let's give him a hand. So, Oying and I traveled to Ethiopia in November of 2014 to meet with Minister Kesete and to learn more about the situation on the ground and what might be done to establish this institute and how Hopkins could help. But even more importantly, as Dr. Kesete mentioned in his presentation, Oying was present at what I call the conception of the Institute when Minister Kesete met with Dean Clegg and President Daniels of our university. And I thought maybe you could reflect on that moment a little bit and share a little bit of your thoughts about that and what's evolved since then, Oying.
Thank you, Henry. So sometime around November 2013, to be exact, a day before the International Conference on Family Planning, which was being held in Addis Ababa, there was a ministerial meeting at the Hilton Hotel in Addis. There were about 16 ministers from all over the world meeting on issue of family planning and demographic dividend. And out of that meeting, Minister Kesete, who was the host of the ministerial meeting, came out, and I was also in that meeting as a technical resource person. And then from that meeting, we walked to the lobby of the Hilton. And very strange, we stood in the lobby for more than an hour, just talking, almost, I think, 1 hour and a half. In fact, when he left, and I was still there waiting for my car, one of the managers of the hotel was joking me and said, "You must be a very, very important person." And I said, "Why?" He said, "Because for a minister of ours to stand in the lobby of the hotel and talk to you for that long, you must be a very important person." So I laughed about that. So in fact, that 1 hour and a half of standing with Minister Kesete, that was when he articulated to me his vision of setting up the International Institute for Primary Health Care. As you know, Ethiopia is hailed as one of the most successful public health program recently in the world through its primary health care approach with the health extension workers. What impressed me the most is that because of where I come from and the work that I do, normally when primary health care becomes the mantra of any country, it means to me that family planning will be sacrificed. That's normally what happens. Primary health care becomes the smokescreen and nobody pays attention to family planning. But in the case of Ethiopia, it's a primary health care which has been able to reduce maternal mortality, reduce infant mortality, reduce under 5 mortality, and many other things. But to me, personally, I was very impressed that it also had spectacular results in the family planning area with such a massive increase in the number of modern method acceptors of family planning in such a short period of time. So when he articulated this vision of setting up an international institute, homegrown but with world standards, so that others in the area can learn from the experience and the challenges of Ethiopia, at the same time to serve its own purpose within Ethiopia. I said to him that I will do everything to see how Hopkins might be able to help you. So actually, within 2 days, I was able to set up a meeting between Minister Kesete, the president of Johns Hopkins University, Ron Daniels, is still the president, and Mike Clegg, who was then the dean of the School of Public Health. And in that meeting, he articulated 2 things, but for the purpose of this seminar, he articulated again his vision for the International Institute for Primary Health Care and whether Johns Hopkins University might be able to help him make this vision a reality. So with the support of the president of the university and the dean of the School of Public Health, which pledged support for him, essentially that's how the Hopkins involvement happened. But there's a side story also to this. Melinda came to that conference, Melinda Gates came to that conference as a speaker. And I also arranged for a meeting between Melinda Gates and Ron Daniels. And I was in that meeting when Melinda asked Ron, and he said, Ron, you are the president of Johns Hopkins University. Did you come to Ethiopia, but then you have other meetings, in other African countries? Essentially, Melinda was trying to see if he came to Ethiopia, but then had other plans to go to other countries for other businesses. And Ron said, oh no, I came to Ethiopia precisely for this. You have the family planning, primary health care, and and Melinda said, so why would a president of a university, just Johns would come? I think the implication there is I would never see a president of Harvard come to a meeting like this, right? She didn't say that, but that was my interpretation. So she asked Ron Daniels, and Ron, without batting an eyelash, just said, Melinda, this is part of the mission of Johns Hopkins University. Because it is part of the mission of Johns Hopkins University, I have to be here. So I just thought I'd tell you that story, because it just shows you the commitment of the university as a whole, not just the School of Public Health, with regards to primary health care and family planning.
Great. Thank you very much. Margaret, perhaps all of us know now of Gates' long support for highly vertical programs that have a technological bent to them. So how is it that Gates decided to jump into this? I'm sure we'd all like to hear that. And what is your understanding of the perspective at Gates towards primary health care now?
Thank you, Henry, and thanks for the opportunity to join you. Apologies for being late. Yes, it was traffic. I had it calculated but did not anticipate Pratt Street. So thank you for being here, and just listening to the history, of course, the long history from our colleague in the health system in Ethiopia, and then Oying relaying some of the original conceptualization of the Institute. I am digging back in my own memory banks, and the day before I delivered my third child, I got approval for a primary healthcare investment strategy for Ethiopia. So I got that approved internally and then went and had a baby and disappeared for 6 months, only to return to work and have another different kind of baby in my email inbox, which was a grant proposal for the Primary Healthcare Institute in Ethiopia. And so it's about as old as my youngest, and I care about both individuals very differently but deeply. And I think to your question, Dr. Perry, the Gates Foundation, yes, of course, has historically been known for its investments in communicable disease, technology development for health, and a lot of work on innovation in the technological space across different development sectors. And more recently, maybe within the past 3 to 4 years, there has been a growing internal appreciation about the importance of primary health care, both for sustaining the gains that might be made with the introduction of new technologies, but also as a development platform itself. And as we watched the video and saw the pictures, I think it's critical to appreciate that while, of course, the health extension worker is this sort of emblematic person for the health sector, the health extension worker is an emblematic individual in the Ethiopian system, and I mean that very broadly. It is a women's empowerment program, it is a jobs program, it is a community development program, and when you talk to health extension workers out in the village and see how valued they are and how critical they are to that community, and you see the little girls who are looking up at these pretty young women as models for who they too can be. I think to your point about things taking time, I actually think this has been transformational within a generation. You referenced Melinda, and of course Bill and Melinda see themselves as impatient optimists, so I understand your expression of patience, a demand to be patient, but I also work for two people who are super impatient and want to see results. And in Ethiopia, the Bill and Melinda Gates Foundation has partnered with that government for years and years on things that they see as equally important for equity and for improving health and livelihoods. We have been investing in Ethiopia for over 15 years, which it is a country that we have a long-standing partnership with. We have an Ethiopia office there and are working across the health, nutrition, and agriculture sectors. And indeed, primary health care cuts across all of those. So in some ways, the foundation's growing appreciation for primary health care comes from being a partner with Ethiopia and seeing how Ethiopia has used primary health care as a platform for both improving health but also improving development. And I think that that's why we were so excited to be a partner with Johns Hopkins and with the Ethiopian government on the Institute. And I think a signal for us about the commitment of the world to primary health care would be more funders coming in to support the Institute and its progress over time. I mean, Ethiopia's budget for the health sector comes from about 50% of that comes from external sources, and surely there's some available resources that could be invested more directly in primary health care. And so we look forward to seeing how the Institute grows and evolves over time.
Great. Thank you very much, Margaret. So, we can applaud that, I think. We've got about 5 minutes left, and we wanted to give you a chance to ask any questions, or if any of you want to make a comment. We have the microphone ready. We need you to speak into the microphone since this is being transmitted throughout the world and will be recorded as well. So if you'd like to ask a question when he has the microphone. Please. Natalie, welcome.
Thanks very much. That was a really nice presentation. This is a question that is maybe kind of basic, but I'm kind of interested in what a training actually involves when somebody, when a group of people are coming and learning about the program.
Okay, thank you. I'll try to answer that in the absence of Professor Mengesha and his team there. It's been interesting to watch the evolution of this over the several years that I've been involved. And in essence, what in fact has happened is different from what we anticipated happening. So we had planned when we wrote our grant to Gates Foundation that there would be 3-day trainings for high-level people, ministers of health, and parliamentarians. We'd have 2-week trainings for program managers at the national level, and we'd have 6-week trainings for people at a lower level. What in fact has happened is that the trainings that have been held have in fact been modified to meet the needs of the groups that come. And I think the longest training that's been held so far has been 5 days or so. And so there hasn't been the demand for the 2-week course that we thought would be there. The other interesting part of it is that the delegations that come have a pretty clear sense of what they want to know and learn about, and so the trainings are tailored to meet the needs of the groups that are coming. The trainings consist of lectures provided in the training center that you saw. A lot of them are given by high-level Ministry of Health staff. Some of them are given by the training staff of the Institute. We do have some recorded lectures from our Hopkins side that are given. And then there is a very strong field component to the training. And so we provide them with 2 or 3 days of experience out in the field, visiting at the health center, visiting at the health post, and going out to the house to see what actually takes place in the household. So it's a challenge to work all this in a matter of 3 to 5 days, but that in fact is what has transpired so far. We're hoping to move towards the 2-week course, and our curriculum will be much more heavily engaged with the Hopkins component than it has been so far. And we're also working on, which hasn't been implemented yet, but working on a online training component for people before they come, and then a training component online after they go home, and some kind of continuing relationship between the Institute and the trainees. But that's still to be developed. This is sort of an organic growth, as it turns out, but that's the way it is now.
Can I comment on that? So the original training design, this could happen if the funding for those trainees, are secured. First, before you come, you go online first. So there's some online stuff that you have to go through before you come. And then when you come, there's the classroom component of it. Then you have a field component. And then when you're finished with the field, I think the last 2 days is for the team to be able to work together and have an action plan going back to their own country. And if there were resources available for the Institute to be able to support and monitor how they execute against the action plan as a team, when they go back to their own countries. Yeah. So that was the way it was designed originally.
Yeah, in fact, I'm glad you brought that up. That part of it is built into the training, giving the trainees a chance to share with the other trainees what their primary healthcare situation is back home, and then over the course of the training, begin to think about and propose what they might hope to see in their own country as they go back, that's been influenced by what they experienced, not only by visiting and learning about the Ethiopian system, but from the other trainees that are in their group. And a lot of these are groups from different countries coming together. Yes, please.
Thank you very much. First, I would like to thank Dr. Dennis Carlson. I read his book on Kusui and it was amazing. I have a question as regards the training. I'm from Nigeria. I practiced and trained in Nigeria before coming for my MPH here. And I observed that a lot of primary health care workers were trained in tertiary institutions. And after being trained in tertiary institutions, then they are sent to primary health care centers to work. First, my question is, do you experience a challenge with that transition, that after having a tertiary health training, being sent to a primary health care setting, having the challenge to identify with the needs of the primary health care setting and not automatically translate everything that they learned in the tertiary health care center to the primary health care center? A typical example would be a patient coming to a tertiary health center for malaria treatment in Nigeria, which is what we see, as opposed to being referred back to primary health care center. So in Ethiopia, do you with the institutes, do you have that challenge? And if you do have that challenge while you're training your staff, how do you mitigate it?
Yeah, thank you very much. I'm not sure I fully understood your question or I can really answer it. The training itself is not technical training. The training that the Institute offers is to give the trainees a vision of what can be accomplished through a stronger primary health care system. It's not focused on the detailed technical aspects of, say, community case management of malaria, for example. We just can't do that in a matter of a short period of time. So, one of the things that I've observed and heard from our training staff as well is that the people who come for the training, they're already sold on primary health care and they know it needs to be stronger in their own countries, and they get all excited by what they've seen that Ethiopia has been able to do, and they wish they could transmit it and translate a lot of the ideas into their home country, and Nigeria is a great example of that. But then they talk about the the reality of going back home where there's not a political commitment to developing a strong primary health care system, and there's not the funding to do it. And so that's going to be another issue that'll be an important part of the training is, what was the political leadership that Ethiopia was able to bring to this, and where did they find the money to invest in this? And so it's a lot of complex issues when you really get into the nuts and bolts of it, and how to go about strengthening a primary health care system. And even though they're simple in a sense, transferring all this is not going to be easy, and that's one of the reasons why the Institute is hoping to develop long-term relationships with groups who come from other countries, and so that the staff of the Institute, and hopefully Hopkins as well, can be a part in a longer-term basis, to go back to Dennis Carlson's basic idea of this takes time to build relationships and hopefully slowly begin to implement some changes that have substance to them. I don't know if that answered your question or not, but I tried. Does anybody else have any questions or comments? It's 12:21, so I guess we need to, sorry, 1:21, excuse me. So I think our time is up, unless there is another burning question or comment. So I want to thank our panelists for being here. Dennis Carlson for coming from Seattle, and Oying Rimon, and then Margaret from driving over here from DC. In particular, thanks to Dr. Kesete and also to Professor Mengesha for their willingness to share their thoughts by video. So thank you for coming.
Thank you.